This T-handle is specially designed because this wire is pretty thin. It's 2.0. Yes, 2.0. On traditional T-handles, we were having problems where it was like getting bound up, like not centered. Like it wasn't really working to go right in the middle. This is now a self-centering T-handle chuck. So as I was very loose right there, I'm getting pressure to make it off center, and as I tighten it, it comes right into the middle. So you don't have to worry about it.
We stole that design, so a lot of us were missing these in our heyday. That's the exact design off of the Suzuki's flexible nail inserter. We just reverse engineered it and made it work.
With this handle too, it used to be something more circular. There's this like large offset or small offset. You can orient the tip of this with this or this however you want, but just so you know now like where it's going. All right, so we're gonna just see kind of where this starts, where it wants to go. Shoot there. All right, so in this plane, this is a little bit of a trick, or like just you have to keep it in your mind that if you see it flat there, it's either coming in or out of the plane. So on the posterior column screw, I'll try to get it down to where I think the pelvic rim is going to be before I check another view, and usually I'll just use that on the AP. So we'll see how this goes. Shoot. So kind of moving that way, and I'll make it go a little more posterior.
So it's always has a bend on it. You just have to...
Always has a bend on it, yeah. Shoot there. Now that's facing, I know, toward the pelvis. So I'm just trying to walk it down so that it doesn't necessarily move anywhere but straight.
ये फ्लेक्सिबल सिस्टम जुबैर ये उसके लिक्विड से डाल रहे हैं पोस्टर कॉलम
में shoot. Now I know this is sort of where I'm close to the brim. Maybe when I go a little more posterior. Can you come to an AP now? So we'll just see kind of where we're at. So that's about how far I would go for this implant, this pathway. I know I'm safe and behind the joint, or at least mostly there. Shoot there. I just want to see how close I am to the brim. So I still got some ways. Now I tilted this pelvis up a little bit. You may have to go that way, like tilt toward the head a little bit. I'm sorry, the foot, my fault. Yep, try that. That's almost. Okay, and a little distal. Shoot there. Yes, we're kind of getting there. I'm going to try to get this a little more close to the brim. So as I spin this, you can do this, but sometimes you don't. Now I can feel it in the spongy plastic, but in bone, usually if I'm like this, I'll just like vibrate it and move it so that it kind of taps in a way that kind of breaks it loose. Now I should be heading toward here at this point. You're asking a question.
Very poronic bone. Don't you come
It's
out
just,
like very easily?
It's just gentle. I try not to get to a cortex without kind of seeing
Yeah.
what's going to happen. Shoot there. So that's what I knew I was doing. Turn this now. Now I'm going to use the wire as a deflector. Shoot. Oh, there you go. Perfect. Let's go back to the iliac oblique view. So just 45. You can leave the tilt. It'll be easier back and forth. Just go there.
You want to maintain like a 2 or 3 finger length there, because if you go too far on the wire, you start getting stuck with that.
Try there. It could be close to the joint without knowing. No, I'm pretty good. So I'll just keep that moving.
Do you feel like you have pretty good control of the wire even at this distance for that length?
I suppose the
Or you have to ever have to take out the cannula to be able to get more control of the wire?
shoot there. So make it a little more comfort.
Cannula keeps the integrity of that wire, because that cannula starts to dip into here,
Uh-huh.
so it's going to maintain the integrity of the wire all the way
through there.
into
Gotcha.
that crest.
Shoot there. So clear and safe behind the joint. Back to the AP. Just double check that this is working. So this looks straight, but the curve is in this plane. But shoot there. So now it's up against it. Okay, so now we're gonna test the integrity of the sawbones, because this is exactly how it you'd want it to be. Yeah. Let me see if I can get that plane a little more. Shoot there. Shoot there. Shoot there.
So you want
So I'm just gonna try to hope that the plastic is strong enough here. Shoot that.
With the guide wires, with the angle.
Oh, I can see it. I can feel it. Yeah. That's just this. I'm gonna try to.
It want to come out inside.
Let's come on inside. Okay. So I'm gonna try to do something practical now. All right. So this, let's say that you asked about osteoporotic bone and so on. So what I'm gonna do is ream a little bit of a opening path right now. Let me see if we can get this thing to work.
And then
Yeah.
redirect, like you
Try
would
to
do with an
redirect it a little bit.
exercise strip.
Yeah, exactly. So let me
smaller size and
see. I'm gonna go off book here for a second.
Flexible.
We're gonna see if we can make this work, because you can do this too, where you can add a little bit of your own bend into the wire.
So can you come back
and then
Yeah, you want to try
a
that?
new
We can do
trajectory?
that.
Or is
That'll be a more practical application. No, it's not that.
It almost shows up too well. That's not real life.
No, but
It's a good question.
Yeah.
crest.
I won't know where I am here, but that's okay. All right, so let's do that.
So this is a flexible streamer system for putting column screws.
Shoot there. Shoot there. All right, let's see if we can change that. Shoot that. Shoot there.
Doing a difficult way.
I think so. Shoot.
There you go.
All right, go to the iliac view. 45 toward you. Shoot there. Just to make sure I'm not hitting. That's okay. Shoot there.
That's pretty neat.
Shoot that. Yeah, right. All right, let me see the AP there again. So like I know like I'm gonna head toward the back, and that's fine if I know what I'm doing, and then I'll just go back to that and change it. Go ahead, shoot. Yeah, so let's try to drive this down. Shoot. All right, let me see the other view. And again, you just want to make sure this is going not at the joint, which is maybe shoot. Shoot. Go all the way around the other way. Shoot. Shoot that. Shoot there. Shoot there. Shoot there. Shoot there. Other view. Also, this is just my own fault. After you've done a couple and you're like comfortable with it, you tend to take less X-ray and just go, go, go. You know, shoot that.
We use elastic nail instead of this.
Shoot that.
Pediatric elastic
Iliac view.
that has got a curve.
You use that.
Oh, that's yeah.
The screw will go over that.
Shoot there.
Yes, the screw will go. The screw will go over it.
Over it.
Cannot screw, yes.
Try to compromise here. Shoot that.
The benefit is if it is if it's going to come out,
Shoot that.
then you rotate it like this. See?
Shoot that.
When you put the screw and you want to take out the wire, the curve will straight and the wire will come out very easily.
Let me see the other view. Hopefully I got past it enough to make a
What size
180 on the
wire
wire.
is
You should pass the screw.
Shoot there.
so like
One point screw.
1.5?
Let me see what that looks like on
No,
the
no,
iliac.
1.82 mm. Not one. I think it's reasonable enough.
Listen,
2
this is,
mm go through the.
Reasonable enough
There you go.
shoot,
for the anterior column, for the posterior column, both.
shoot that. Keeping me honest in here. Let me see the AP. Hopefully, if I'm that deep, it's made enough turn around the brim to where we're okay. Yeah, I think so.
Yeah.
I'll like that. Shoot there. Shoot there. Iliac. Well, like, do you guys do like the retrograde, like the shield screw with the leg up there?
The butthole screw.
The butthole screw.
Yeah.
Shoot that.
Like especially in fat people, it's very difficult.
Shoot that. Very good.
It makes life easier.
We should try to be near to the cup because we should try to be near to the cup that side because this will try to come out this way. If we keep ourselves that way toward the cup, acetabular,
Yeah.
I think that's more reasonable.
It's a little wider there too. Like as you get toward the ischial spine, it kind of narrows like a triangle. So it's a little, you can go to the AP Lee.
This is the difficult area. Otherwise, because
This is the hardest one.
Hardest,
They,
yeah.
they wanted me to start on that one.
we use elastic, pediatric elastic wires.
Oh, do you?
Yes, yes.
Shoot there. Shoot that. So if you wanted to get past the notch, go back to the 45-degree view. You're pretty much there. If you want to go for broke and get down to the issue, we'll try to do that. Shoot there. I gotta get this one.
Practical experience.
Yeah.
Navigating across fracture lines.
Not bad because if it's a really displaced fracture, like let's say you have a big crest displacement, like from an anterior column, you gotta open that and like put a screw into the clamp and get it. This is really not an obtainer of reduction. It's more of a maintainer, you know. Shoot that. I'm trying to spin this in place, which is hard. Shoot that. Also, as I was just doing that, so I try not to go more than 360 degrees in one direction because then you just torque the wire and like kink it a little bit. So I was like maxing out there, so I'm gonna come back the other way.
You can build tension in it too.
And then it can break.
Yeah, no, it's it'll
just
build
deforms.
tension, and then all of a sudden it'll like spring out.
Shoot
It
that.
may break too.
Have you ever had these wires break past the reamer, or what do you?
Wire not, reamer yes.
Reamer, yeah.
We have 90. I've only seen I think 190.
ये flexible reamer है.
Shoot there.
Just take it home.
At this point, yeah. Shoot there. Let me see the iliac view one more time. We're pretty much there at this point. You can stop at this point. That's good enough. I'll just stop. For the points of the demonstration, like I would probably, if this was a real patient, I would probably back this thing up to here,
And then
try to
go
drive
down.
it just a hair more posterior and kind of mess with it.
Right.
But just so we can get through all this stuff, I think this is pretty fine. Go back to the AP. I think this looks good too.
So this is going posterior toward the ischium. Trying
Yes.
to come out posterior.
This one is trying to come out anterior. Just
Okay, into this anterior.
Yeah, I would probably back it up, turn it, go back the other way. But this is pretty deep down. I mean, you're below the joint.
This is near the anterior.
What's that?
Is it near the anterior? In
well,
the
it's gonna
stem,
come
in
out
the
this way.
stem.
Uh,
In the stem, is it coming? Try to come out near
This
near
is
anterior
trying
or
to-
posterior?
Currently, right now, this is trying to come out in the subcotyloid fossa, like on the anterior ischium. Like if
Where?
you do like
Can
your
you show
ischial
where
cut,
it's
yeah,
coming
yeah.
out?
What's that?
Can you show us where it's coming, trying to come out?
Yeah. Well, I can just, do we just
Yeah,
punch it out?
yeah.
Just so you can see where it is?
Okay,
Yeah, I can just
okay,
punch
okay.
it out. Again, I wouldn't do this. I
Because
recommend
for us,
it,
we don't
but
get the idea.
I can just show you where
Or
it's going.
operatively, we don't get the idea where it's coming out.
Yeah, sure. You want me to try to fix it or just pop it out?
Just pop it out where
Pop
it's
it
come
out,
out. Where
okay.
it come out.
All right, Darren, you heard? I didn't do it. Surgery.
I heard it.
I heard it's all records. Here, go to the iliac view. You'll be able to see it on this view better. Oh, I can pull the whole model.
Go do
Yeah.
a lab with you guys.
Shoot that.
I
See, it's like kinda
Already
right on-
coming
yeah.
thing.
There it goes. Shoot. So that's probably out.
So far,
No, it's actually not either.
I think you'd send it open as well.
Yeah.
still we are in.
But it's
Still
pretty,
we are in.
pretty damn deep. I'll just show you how to put that.
Perhaps we feel that it has come out, but it hasn't come out.
It hasn't.
There you are, there's the best.
Go to your ball.
I'll see if I can turn it, and then that would really go home.
Did you see it? What did you see?
So far, excellent.
Shoot there. Your hand is good. Shoot. Yeah, it was just
yeah, I was
a
trying to go to the
cortical
anterior
overlap.
issue.
Shoot that. Shoot that. There it goes, starting to curve. Shoot. That's pretty far down there.
Fine.
That's stayed in the whole way. All right, let's go to the AP, and then we'll put one in.
Quite enough. Cross the fracture.
There's a cross.
It has crossed the fracture.
Shoot there. Yeah, that's in there. Okay. So the measuring
Oh,
device
yeah.
here. We'll take this out and measure next. This little rounded area, you just want to hub that down and make sure it's a pretty hard stop. So the longest implant is a 210. This is measuring between a 200 and a 210. You want to go shorter. And then I showed some of the guys this. The implants now, there's a lot of flexibility in them, like almost where you can bend it like a full like rainbow. In order to do that, you have to have some gaps in these links. So there's a little bit of length discrepancy when it's fully deployed and fully compressed position. If you turn this over, it'll tell you how many millimeters that would change from full short to full long. So at a 207, it's probably going to change up to 16 millimeters. So we put in a 200 at that point. You can even go to 190.
Sorry. So you say this is the extended length, and the other one is the compressed length.
This is just the difference from full compressed to full. So there's a
Oh, I
change
see.
in
Got
up
it.
to
I mean, the implant
15 millimeters.
Got it.
Okay? So I'll put in a 190 just to make sure I don't go long out there. Okay.
compression and
So this is the screw.
down, pretty substantial.
This is the actual implant. Yeah. I don't know what size this is.
Yeah.
ये implant
What size
डालेगा,
is this one?
visual implant
I'll
डालेगा.
just use this one. That's fine. So if you wanted to, and you had the tube situation, you could do this. Like, we'll show you in the anterior column and pin it, but the reamer will fit through this middle tube. Okay, so we've measured. Now we're gonna ream, and I'll ream once, typically with a 6.5.
Remote be flexible.
I have a 6.0 loaded, so if you're 6.5.
Yeah. After this, because the ball tip is on, the implant will not go over the ball tip. There's a smooth wire. In order to do the smooth wire, you have to do this exchange tube, which just with this handle never used to exist, and it's so much easier with that. And it's narrower. Like, you used to have to ream to a 7.0 for a 7.5 implant, so there's not a lot of change there. And you want to do this on drill, not ream, actually. Shoot that.
When you're doing it, do you keep it running or do you stop it?
I stop it. Yeah, that's okay.
It doesn't take a while to run.
No, shoot. We're getting to the bend now. You might see some bone flake out right there.
Never stop it.
Yep.
Did it do it?
Yep.
Yeah. Just a hair. I can tell it was close. Shoot.
Is it come out? No.
Yeah, not much. Not much.
No,
That's not bad.
no, not at all.
Shoot there. Shoot there. All right, so we're all the way down. I'll just make sure this isn't with an operator if you want, or just if you run. Shoot. Shoot.
We have to do searches now that are actually going reverse. They're doing like an SI, they're getting really close.
Okay, so we're reamed at this point. The next step is to use the exchange tube. You can use, there's an instrument, let's say you were getting, like you wanted to cross the symphysis and you run into some cortex, or you wanted to go across an SI joint and you run into some cortex. There's a larger tube that you can introduce. This is a long, flexible drill tip wire, so if you want to go through cortex, so we'll use this in the back when we get to it, just so you know the difference. The tube is a little bit bigger, and that's what that's for. So I put this in by twisting and pushing, and that will help it not get bound. Shoot that. And it's radio opaque, so you can see it kind of coming down, and we're sort of stopped right in the middle there. So just like twist and push and twist and push and shoot.
So the idea is
Don't
to get
further
this
down.
across the fracture line.
This was tougher on the older model, and sometimes on big shoot.
And so at minimum, do you have to at least get a 6.5 to be able to instrument getting that in through a little
6.5
bit?
is absolute minimum. That's why it's not good. If I did a 7, it would like fall right down.
Okay.
But I don't know why I didn't. There it goes. Shoot. So just a little bit of push, and you can see it's down all the way.
What is the diameter of the screw?
All right. So
I
when
think it's
that's-
7.5.
Yeah. When that's in there, this is now what's maintaining your position of where your ultimate implant. So you can just pull this, and you can see what it does. Like this was straight and just going around. Like so, the wire does bend when it's in there, and you're just redirecting the tip. So it does deform like that.
So the wall thickness.
So this is in, and now you would put a smooth tip wire. And if you think you're gonna forget this stuff, like I have many times, you can't. The implant will physically go over that bigger wire.
Yeah.
So shoot. This goes all the way down. Occasionally, if you're on a real tight bend, like let's say you're doing the symphysis, it just meets it at an angle that's very hard. So I'll put like replicate that little bend just on the tip, just like a 20, 30 degree bend, and then you just have to drive it again with the T handle, and it'll go past it. So the wire, smooth wire's in. This can come out.
So it perforates the tube.
It can. Well, only on real sharp. I mean that's a pretty decent bend, and it didn't even come close here. But like really, where I've seen it is the symphysis. Yeah. Okay, so we have that across, and now the next thing is our implant. So I'm going to put this on so you can show you guys. So it's all nice and color coded. Yellow is 7.5, and there's 2 diameters. The bigger one is 9.5. I almost always use a 7.5 outside of the posterior ring. It's a little more flexible of an implant, and it's just I don't know. It fits in the anterior column a lot better. You don't have any worry about the implant being too big to fit within the ramus. And this just screws on just, you know. There you go. All right, So the T-handle, this is so much easier than the previous set of instrumentation. So just
Can't put it in by power.
I like you. Yeah, do whatever I can by power.
Anything in.
Yeah.
That's
Yeah.
a delicate engineering feat.
So I usually maintain a little bit of forward pressure and then just keep turning it. It's a little bit different than a traditional screw because the threads are kind of limited. So the insertion usually requires a little bit of forward pressure, but not crazy. Just keep going until you're fully seated. I'll put a washer on. This isn't going to make much sense to put a washer. When we do the back, we'll put a washer, but they'll fit on that also. Turn. Shoot. Just give you some progress shots. Making the bend. My biggest piece of advice when you're first trying this is just to have a bit of patience, especially when you're just learning how to drive that wire. Even when I was doing it early on, I would like kind of make it wrong and then try to correct it and just like get a feel for how it changes when you're moving its different directions and how that wire feels in different bone densities. We're almost down to the end. So now we're fully seated. Shoot that. There you go. Big dog. Now, a lot of people ask this question, so before you even ask, I'll address it. There is a countersink if you're doing this in particular because it does sit kind of proud of the belts. So I didn't do it in this case, but it's somewhere around here. They didn't bring it in the demo sets, but I usually will run a countersink. It looks just like this. There's a little bubble like this, but the bubble has flutes, so it carves out a perfect little semicircular dip. All right, so then once that goes in, the wire comes out. Sorry about that. And this bends a little bit. There you go. So this is very important. You want to make sure. Oh, really? Okay. So you want to make sure green is locked and red is unlocked. You have to make sure you put this in the unlocked position because it'll go into a different position and it won't like grab right. So unlocked all the way down.
This is to unlock the system. Unlock the system.
This is to lock the system. Yep. Now, you can hold this with your hands, but there's just a little counter torque wrench if you like to make sure that you have it in the right position, and then it's just click until you see green. That's it. That's it.
And so you probably see now that it's, if you do an X-ray, is it like
No. So I think I heard you talking about this. It doesn't like expand or contract when you lock it. It statically fixes it.
Okay.
But you gave me a good idea.
because that's what I thought is like you can create compression with that because if you lock it, it would actually like get smaller, but that's not the case.
It's not the case. No, it just fixes.
If you
those
don't lock
cables.
it, then
What's that?
if you don't lock it,
If you don't lock it, then it's still kind of floppy. So the biggest thing that got me interested in this is first in the posterior ring, is that if you have a fixed, bent implant, it's like trying to ride a bicycle on a bent axle. Like it can't rotate. If it's like curved, but it's rigid, it can't rotate like that, and it can't walk out like that. It's fixed that way. Now in the answer column, I like it because it's a curved structure and it's easier to circulate. Now, you really should lock it. That's the intention, is to make it stiff like that. And that's it. And this thing comes off just with the same. So not too bad. Now we're going to try to navigate multiple corridors.